Press all the buttons.
There are so many bloody...
I'm exhausted.
Yeah, go. Welcome everyone to the latest edition of the Orthohub C1 Do 1 podcast. We're really delighted to have a superstar guest with us. Superstar. And we don't say that lightly. First, a bit of housekeeping. So we need to check how to pronounce our guest's name properly. You know, there's certain words that you see written down and you pronounce them for years and then you find out later you've been pronouncing it wrong. Like, Pete, you know there's that berry? A-C-A-I. You know that berry? A-C-A-I?
Yeah.
Do you know how to pronounce it?
I call it an Akai.
So I call it Akai. Yeah, AK. And you know, whenever you're basically on a website and it kind of says like, you know, you're randomly searching something and it kind of says, look here to see pictures of Kelly Kapowski from Saved by the Bell. And you go through it, it's on page 47. At the bottom of every page is a picture of like tooth whitening mid stuff and something to do with ACA berry. So I found out later it's pronounced acai. I imagine that you're all over that, Heather. It's a very American thing, isn't it? Oh. Acai berry. And I've been calling it AK berry. It's a bit
I've been doing that incorrectly the whole time, so I'm with you.
Well, it's like you know, Keanu Reeves. I thought it was Keanu Reeves for years. So I need to check before we start, please, because I've seen your name written so many times. I've read so many of your papers because I'm an academic, Pete, and I've seen it, and I've always read it as Heather Vallier.
Everyone in England, everyone it seems to be in Europe calls you Heather Vallier.
Vallier, and.
Yeah,
is that
I guess
right?
it would be more correct, particularly if you were trying to pronounce it the French way that it was intended. At some point, it got Americanized and it became Vallier.
Vallier, okay. So Heather Vallier from now on. You realize we've just fixed about 1,000 journal clubs around the world.
Or maybe not. There's people who I mention that to, and they say, well, I don't like that as much, so they just do the other way.
I'll call you what I want.
I'm okay with that.
Our guest today is an orthopedic traumatologist who grew up in Milwaukee, Wisconsin, which is very famous for its signature cheese curds and its beer brewing. But for me, it'll always be the place where TV show Happy Days was set. Ralph, Mouth and Potsy, there's one for the kids out there, just Google it. And I absolutely loved Happy Days. Did you ever, you must have had lots of, seen it when you were growing up?
Yeah, we loved Happy Days. And then Laverne and Shirley, they were on back to back.
The spin-off.
Every Tuesday, I watched that show.
And then was it Scott? And then was it Joni Loved Chachi? There was so many spin-offs from that one show.
Oh yeah. That was popular for many years.
That was awesome. No, I loved it. See, the reason Pete's looking lost is he famously grew up without a TV. He used to get thrashed by the butler daily. Did you ever see Happy Days?
That explains a lot of things.
No.
You've never seen Happy Days?
I used to, now and then I would go around to other people's houses.
Yeah.
And because I didn't have a TV till I was about age 18. And so there was the only access to it was around other people's houses. Okay. Occasionally you go and visit someone, and literally my brother and I would just go and sit on their couch and just be like,
like you're in a speakeasy or something.
Yeah. Oh my God.
So Happy Days wasn't a thing for you?
No.
Monday, Tuesday, Happy Days.
Yeah, I'm familiar with the song, but
it sounds just like that. So I love American culture, even though it doesn't love me back. And I really want to go to Milwaukee one day just to see the Fonzie statue, the bronze Fonz down the waterfront. So, so you were once an exercise instructor in Milwaukee.
I was. Yeah. And it's really funny.
What was your signature exercise? What did you get them doing? What was the thing you really liked beasting them with?
Well, it was mostly aerobic dance and calisthenic classes. Usually back in the 80s, that was very popular. And so when I was an undergraduate at Northwestern, one of the exercise classes was taught by a friend of mine who lived down the hall. And then she said, well, would you help me teach? Because I'm going to be away on some interviews and then maybe you could do the class. And I'm like, I don't know if I'm really qualified to do that.
Right.
So
turns out you were.
It was a choice between not working out at all with the group or doing that. I decided to learn how. And then I realized I could make some money doing it. So I used it to earn a little cash on the side while I was going to school, and I would teach a lot of classes, and most of them were just at the university, but then there were these little private clubs where they paid quite a lot of money for a class. And it was actually pretty easy because the people who were there were not really in that good of shape, and they didn't need
and the 80s was kind of very much big aerobics, was big hair, leg warmers, that kind of, is it that kind of vibe?
Oh yeah.
Awesome.
Completely.
Awesome.
Headbands.
Yeah. Big permed hair, headbands.
Neon.
Yeah, the whole thing.
A lot of neon. So you went to college at
North. We used to get free shoes. There was the Reebok shoe company used to give us shoes, and I love that too because the shoes are like pretty expensive, and so we would try their shoes for them. So I got a bunch of shoes.
Reebok, well, no, and they had the Reebok Classic was the one, and then they had the one called Reebok Pump, where you'd pump
with the little pump thing,
the pump in the tongue, and the thing would come up. Yeah, I know.
Oh, yeah.
Yeah. So you went to college at Northwestern University in Illinois. You majored in biochemistry and molecular cell biology. Now, forgive me, if someone majors, does that mean you have to have a minor or not?
You could have a minor in addition to that, but the major actually encompassed a whole bunch of different types of science in this case.
Right, I think. So you went to med school at Stanford, actually, and where you were there, you took an extra year to do research, and that's where you met your husband, who's a graduate student, and you got married at medical school.
Yep.
And we'll come back to that actually later, because you went on to residency back home at the University of Wisconsin, and then fellowship in trauma at Harborview in Seattle, which is the birthplace of Starbucks.
Is it?
Yes, it is.
Yeah. So they've got the first ever Starbucks there. It's called Pike Place Market, and I went there. Almost got mugged outside. It's pretty rough around there in Seattle at night time. By the waterfront. But I know I'll put a photo up there because I've got a photo of when I was outside it. You must have been to Pike Place.
Oh yeah, lots of times.
Yeah. No, I'm a big Starbucks connoisseur. I'm not a classy guy.
So when was that? 2000.
This has been about 2008.
Right.
When I went there, not for work. I've got
images in my head. You know, Starbucks got come under a lot of criticism because they had the tap running constantly.
Okay.
There's something about the process of coffee making that meant that they had to have a tap running constantly,
like a constant drip.
A constant drip.
Yeah.
And I'm just thinking this constant drip, this tap running ever since 2007 or wherever it was.
In about 1 million Starbucks around the world.
Right, exactly.
Yeah. And then you were appointed to a substantive post at MetroHealth in Cleveland, which is a level 1 trauma center affiliated with Case Weston Reserve University, which is where you are now a professor of orthopedics, and you are the medical director of trauma recovery services at MetroHealth, Cleveland, Ohio.
Yes.
Have we missed anything out so far?
Well, there's a lot of things that I'm not sure very many people might want to know, or that I might not want them to know.
No, that's fair enough. We'll
leave it at that.
We're going by what's. We haven't got the FBI records. We've just got what's available in the public domain.
Sounds good for a starter.
Okay, so you are truly a colossus of research output around orthopedic trauma. Over 150 peer-reviewed articles, 20-odd book chapters, Educator of the Year, a key collaborator on the Pete's written here, frankly awesome OE website, OrthoEvidence, with our friend Mo Bandari. A genuine pioneer in the holistic patient recovery after trauma, the 36th president of the OTA, and the first ever female president. And also, and the other thing is that your name is mentioned every time there's a lecture, discussion, journal club on the topic of orthopedic polytrauma anywhere in the world, your name comes up, and now people can pronounce it properly. Heather, welcome to OrthoHub.
Thank you so much for having me, you guys.
Sorry to interrupt. We need your help. There is a thing called a call to action. This is a call to action to everyone who likes OrthoHub. We don't want your money. We just need your support. So it is very important if you're watching on YouTube right now that you go down, you click a like button. It's a thumbs up thing. You click the subscribe, and then we need you to turn on notifications. So every time there's a new video, you know that it's there and it's waiting for you. Make sense?
Makes sense. Click on subscribe.
The other thing is, if you're on Apple Podcasts, please can you leave a comment and leave us some feedback and a review. Ideally 5 stars.
We've got some reviews.
We've got some reviews. Here we are. Pete, do you want to...
Amazing podcast, sharing a treasure trove of knowledge and ideas presented in a relaxed manner. Have learnt loads listening to them. The best motivating and inspiring to me will certainly benefit from more to come.
Who's that?
That was Ben Doc.
Bone Doc, I think.
Bone Doc.
Bone Doc, not Ben Doc. Bone Doc. So the year 2 medic at GKT. As someone who went to Mary's and then Imperial, we don't like GKT. But I do love this guy. Or girl. So just started as an FY1, and this podcast always reminds me why I want to pursue a career in TNO. 3 words to describe this podcast: entertaining, inspirational, and educational. That's really quite touching.
My personal favourite is from Nikki
said go.
Nikki said go. I love it. It's really good for getting to sleep at night. That's what Chloe has said many a time.
Yeah, I really don't know how to feel about that. I feel quite traumatized by that. So it's good. So this is just to prove to you that we do actually read your comments. Pete's got YouTube open. Tell us about some YouTube comments.
Miss Ang, so this is following the Miss Ang one that we did release recently. Miss Ang was my tutor for a short while in medical school and inspired me to start a new career in orthopedics. Great series. Keep it going, guys.
There's a bunch of comments under there, and we do read these, and we do respond. What else have you got?
Wonderful interview, laughter and sadness and everything else. So happy she's has such fine colleagues at work. All the best to your channel.
I've got on Twitter here. Moe Zaiton says, amazing podcast, Cash Actor. There's no Pete Bates on this one. Like there, you see. It's great that more people will know about her important work. Dad worked with Sui in 1990 up north. She has been an inspiration for me ever since I read her book when I was in primary school, of which I still have a personalised signed first edition.
So thanks for your comments. It's great to have them, and please send us more. Subscribe and like because that increases our hits and makes us look good.
It makes us no money, so don't.
It makes us no money whatsoever. It just makes us feel better.
It makes us feel better. It makes us feel like we're not shouting to the void and people are listening. And if you, wherever you are, please do interact with us, be it on Twitter, on LinkedIn, on Instagram. We don't have a TikTok. And please...
Well, you've got to get a TikTok.
You'll have to do some dances then. Are you okay to do some of those?
And now, back to the podcast. Heather, I'll be honest, you've always been a bit of a hero of mine, secretly. And I remember when I first met you in Edinburgh. It was the Edinburgh Trauma Symposium. You were, we were on the. I'd been invited to go up and give a talk. So the plane was a bit late arriving. I was a bit late anyway, and so I arrived in a bit of a fluster. I hadn't really written my talks fully yet, so I was a little bit flustered and stressed. I hadn't really focused on what else was going on at the symposium. It was just a case of getting there and delivering the talk. So I turn up, and I walk into the auditorium a little bit late, about 10 minutes in to one of the keynotes, and it's packed, absolutely packed. So I'm like sneaking up the side, because it's a little bit awkward. Everyone's looking over when you walk in late, and there's this lady up on stage talking and talking about like the systemic effects of polytrauma. I thought, that's quite interesting. A bit annoyed that I'd missed the first 10 minutes of it. Anyway, here we are. I'll start watching, and as time goes on, I can be a bit slow at times. It took me about 5 minutes to realise like who this person actually was. Oh my God, it's Heather Vallier. And then I was a little bit starstruck, I have to be saying. Afterwards, we met up in the foyer, and Heather was like very good, just put me at ease immediately. But I was like, oh, great talk.
Well, it's interesting because we want to talk about how you got into trauma and what the draw was, because traumatologists in North America are the best of the best. People like you, Mo Bendari, Paul Tanete, Yelena Bogdan, they're all friends of the show. They've all been on the podcast as guests. But in the UK, it's really not like that. The trauma surgeons over here, those who basically aren't good enough to subspecialize and end up only doing trauma. Wouldn't you agree, Pete?
Oh, that really stings.
I'm only joking, because last thing I need is death threats from Alex Trumpeter poking me to death with an olive wire. So how did you get into trauma? Tell us about that, please.
Sure. So, when I first got interested in orthopedics, my first mentors were actually pediatric orthopedic surgeons. And so I felt like, oh, that's really cool. I could do that and be around kids. And then I realized that I really didn't like a lot of the parents enough to do that longer term. So my exposure as a resident was first through trauma, because we did 3 months of orthopedic trauma the intern year, and I loved it. I loved the physiology and the team-based care, and there was just so much going on. There were always a lot of cases to be done, so there was always an OR that needed somebody to go and scrub. And so I really enjoyed the environment and the team-based care, the idea that we were kind of treating every patient just slightly differently, yet we were following algorithms for the basic pieces of it. And so I was really drawn to that. But the work hours and the conditions, albeit with fun people, were really not very good. We were very, very understaffed, and so it was difficult. And so I spent the better part of a couple of years trying to convince myself that I really didn't want to do orthopedic trauma. I was going to do general orthopedics or maybe foot and ankle, maybe not peds, because I had kind of written that one off. But I liked everything a little bit. Yet the passion for me really was in trauma. And I think it was around the pieces of team-based care, the creativity, the uniting with the whole physiological side of the patient, that I felt there were a lot of unanswered questions, and it would be fun to do that for a career path. And so once I finally acknowledged that that's where my heart was really taking me, I started meeting some other people in the field, and we applied for fellowships during our 4th year out of 5 years. of residency. And so at that time in the United States, hardly anybody was doing trauma. It was a much different climate than it is now. Trauma was kind of like the thing that you did on the side when
Yeah.
all your other cases that you planned for the day were done. You'd squeeze in the trauma
Yeah.
cases. And so trauma was sort of like the leftover work, maybe
Mm.
really didn't warrant a fellowship because everybody did trauma anyway, don't you
Yeah.
know? And so there's a lot of that attitude that had carried over through the late 90s.
It's still
Yet
like
I
that
was
in a lot of the
fortunate to
world. Sorry
have
to
good
interrupt.
mentors. Yeah, it's variable. There's a lot of pockets of different attitudes and cultures that still exist.
Mm.
And it's interesting because depending on where you trained and what type of practice setting you've been in, many orthopedic surgeons are really quite good at taking care of various orthopedic injuries, and some of them very complicated. I
Mm.
think the piece that gets left out is the multiply injured patient, because if you're just sort
For
of
sure.
working at a place on your own,
Mm.
you're really not with a team of people and you're not doing that multiple system injury type of care that we're
Yeah.
all familiar with.
Mm.
But that was kind of how I got my entry into it. And the year I applied for fellowship, there were only about a dozen of us in the United States that were going into trauma that year. So I kind of knew everybody. We all knew each other on the
Right.
interview trail because we were all applying to the same handful of places, and ended up in Seattle, as you said, which was really a wonderful experience. It was extremely busy. There was a lot of great work going on, and it was a good place to train and get an immersion into care of the multiply injured patient, complex articular work, post traumatic reconstruction. Really, a lot of clinical experience, a lot of mentors, and a lot of networking that arose from that, that helped me to effectively position myself for the next phase of my career.
And at that time, were there many female role models in trauma?
No, no, there really weren't. There really weren't. And in fact, it's funny because I first met a woman who was a general surgeon toward the latter part of medical school. And um, she was actually quite abrasive and difficult to be around. So it was somewhat of a disappointing experience. And so I'll refrain from mentioning who
That's
that
just
is.
general
But
surgeons in general. That's what I
yeah, and
like.
I realized a lot of them are kind of unhappy. So
Yeah.
that was sad. But yeah, Amy Ladd is a hand surgeon who's very internationally recognized, and she became on the faculty at Stanford shortly before I left. I had already decided on a career in orthopedics, and so I met her a little bit late in the game, but she was very kind to me and tried to help me with my transition and my um, package as I was getting on the residency trail and that sort of thing. And we've been in contact a little bit here and there since then. And so that was really a wonderful opportunity to meet her, see her, and I got to scrub with her a little bit too because I didn't know any women in orthopedics
Mm.
at the time. And in trauma, there really weren't very many. There were a couple ahead of me, and probably the one person that people recognize most would be Kathy Kramer. And I
Mhm.
met Kathy at the first OTA meeting that I attended in 1999, and she was very kind to me. Tried to give me some tips about things in Seattle and what it would be like. And I just remember thinking, wow, it's really neat. This woman is doing trauma too, because I hadn't known anyone before that.
Yeah.
And she seemed to be a really wonderful person, very respected by her peers, very bright, capable, fun to be around. And so that's neat. And sadly, a couple of years after that, she developed breast cancer and she died. And so that was a huge loss to
Real
the
loss.
orthopedic trauma community. But since then, there have been a pretty good groundswell of women, I think, going into trauma.
Mm.
And
Yeah.
I don't know.
No, well, it's interesting because when you we did a podcast on diversity, and and there's this phrase, if you can't see it, then you can't be it. And so it's harder for trailblazers like you who go into a field there's no one there. But actually, now everyone coming in can look at you and look at some of your peers, and so it's a real positive in the way that you develop that.
Well, it's a funny thing. I think we all like what we do, and we tend to find people that we enjoy being around who like the same types of things, and so it's
Yeah.
very affirming. And
Mm.
I've had the good fortune to know a lot of wonderful men and fewer women, just because there's not as many, I think, who are interested in what we do. But you're right. I think to some extent, if you can't picture yourself in that position, whether it's your sex, gender, your background, it's very difficult to see yourself in that place if there's no role models that match who you are. So I'm sensitive to that. Yet at the same time, it's interesting because that's one of the questions I get asked most often is, well, why aren't there more women in orthopedics, or why aren't there more women in trauma? And I think, well, maybe they just don't like it as much.
Yeah.
You guys, I mean, Yelena
Yes.
Bogdan, I'm gonna have to borrow a quote because she likes to say, well, why aren't we bemoaning that there aren't more women in the crab fishing industry?
Yeah.
They're not.
Because it's a pretty shitty thing to do.
And it's things it kind of goes into different areas too. And I guess just you have to pick out what do you want to be upset about. And so as long as it's fair and people are regarded with respect for who they are and all that, that's good. I just think that some of the work that we do isn't as appealing to women as much as it is to men.
Yeah, but it's not appealing to certain men either. So it's not as though it's all proportionate. The thing that's interesting is that about 50% of the medical students, more than 50%, get on for 80% in the UK are female. And then as you kind of go through the ranks, there's a real attrition rate. 20% of our residents, our registrars, are female. About 6% of consultants or attendings are female, just generally in the generality of orthopedics. I was just wondering how that compares to the US.
Yeah, it falls off. Actually, I think it falls off a lot more sharply because about half of the medical school student bodies, depending on where you look, varies a little bit geographically, about 50-50 men, women. And then as you get into surgical fields, the number of women goes down a little bit, but particularly in orthopedics, thoracic surgery, cardiac surgery, those areas, very few women. And then beyond that, it's interesting because if you look at like whether you practice in an academic or non-academic setting, in a non-academic setting, it's actually a little bit less women. Women are migrating a little bit more now in toward academic positions.
Okay.
Trauma and spine surgery tend to be have less women in those areas, but it's slowly changing over time. I just don't think during our lifetime, I don't think it's going to change a lot more. I think it'll change a little bit, but maybe it'll always be somewhat of a different background. And the physical element about it too is one I think that a lot of the younger women are turned off by, thinking like, oh, you have to be really strong to do this. And you don't necessarily, but you do. And you have to be mentally strong. And I think men and women can both do that if it's something they're passionate about. But also the physical part, it does take its toll on your body. And so if you're of smaller body habitus or maybe not physically as strong in lifting capability and grip and endurance, it could be more difficult and maybe off-putting.
Are you aiming this at me now, Heather? Because I'm feeling like I've been picked on here.
She's calling you a wuss.
No, absolutely.
She's going to put a headband on,
sweatband. Drop it in 20.
Exercise instructor days, right?
Yeah. Let's see some burpees.
I mean, there's a lot of there's a lot of challenges that disproportionately affect women. You had your first child at medical school, and then a daughter as an intern. That must have been a crazy time, an exciting time. But you guys work hard in the US. I'm not saying we don't, but in the US, we know there's always a culture of working hard. There's no annual leave, or that's the emphasis. And then, particularly as an intern, they're beasting you at times. How did you find that with 2 kids?
Yeah, it's weird. It's really difficult. I think there's been large chunks of my life where I've just decided like, okay, well, we're going to do this now. And so being relatively naive about it was probably a good thing because then you just say like, yes, I'm going to do this. I've set some goals. This is the timeline. Here I go. And if I knew more information about it or how unusual that was, maybe I wouldn't have been as gung-ho to want to try it. But that naivety, I think, kind of helped me along the way. It's a funny thing. You mentioned earlier when you were introducing me with those kind words. I was at Stanford in medical school, and I met my husband, who was a graduate student at the time, and we realized that we wanted to get married. And then I'm looking at the timeline of how do we do this? How do we synchronize our schedules with you're going to finish your thesis around this time, but that's not exactly when I need to start my residency, but we might need to move. Will we live apart? All of these questions that many, many couples face in one form or another. But the issue around children, which we both wanted to have, was one where I kind of always thought I would wait until after my residency training was over, but then you're substantially older, and maybe that's a factor. Age could be difficult to have children, and so we had a very tight window where I was taking an extra year to try to synchronize my schedule with his so that we could leave California potentially at the same time. And we said, well, maybe since you have that extra year, if it works out and we can start our family, then it was meant to be. And we'll do it that way. Which is exactly what happened.
Let fate decide.
My son was born, in that end of my clinical stay at medical school. So I could take 3 months off, and it didn't matter because it didn't mess up my residency applications and things, because I had that 1 year to play with. And so he was young, and so we just took turns taking care of him. And my husband worked a lot. He used to go back to his lab at night after dinner and then work overnight and then come home in the morning, so that we could kind of tag off and we wouldn't have to have our son be in childcare for very long. First, it was super expensive. And second of all, we wanted to be able to take care of him. But what it meant was we were kind of living on opposite hours, because my husband was literally up all night, every night, working toward his PhD for a couple of years. The crazy thing is that isn't kind of weird enough. After my son was born, we said, well, we still want to have another child. So when's a good time to do that? And I was on the interview trail for residency positions, and I met this woman in Pittsburgh who had 3 children, and I was just amazed. And I said, wow, this is unbelievable.
Like a
and
pilgrim.
She's like, well, I have one that's an infant right now, and she was a graduating chief. And I said, that's just amazing. I think you might be the only woman that's ever done that in the United States, because there's not a lot of women in residency or otherwise, and I haven't met any that have had children at that point in time. And she said, yeah, well, the best time to do it is actually when you're an intern. And again, I thought, whoa, that's totally crazy.
That's mind-blowing.
Who would do that? That's a really hard year. Is that even possible? You have to at least be with your husband once, at least, for it to happen. But who knows?
Yeah.
And she said, no, really, because you're not really doing orthopedics yet. And so if you miss a few weeks, and maybe they get angry at you for being gone, but it doesn't matter because you're not really in ortho. And so it was a good time to do it.
Yeah.
So I was kind of mulling that around, and I headed back home, and I mentioned that to my husband. He's like, whoa, that's totally crazy. I don't know if we can ever do that. So what did we do? Same thing. Like, well, we have a little window. So if it works, it was meant to be. And then our children will be like, 2 years apart. It'll be just right. Yeah. It's exactly what happened. Like, pretty sure we probably got pregnant on match day. And there you have it.
Best time to celebrate.
When I was an intern, and I had to take, you could take up to 6 weeks off in the United States and still be board eligible, because you can miss up to 6 weeks of 1 year and still be able to sit for your part 1 of your boards at the end of your 5 years of residency. And so that was what we did. And it was a challenging time. I was surprised that there was a lot of animosity amongst some of the leadership in the department, that wasn't a good thing, or that it wasn't doable. And I hadn't even been working with them yet. And so that was disappointing, but I think it's just the nature of the time that we lived in. And so it did work out. And it's funny because when you're pregnant and you're running around and you're an intern, it was really exhausting. I felt this extra energy and this positivity the whole time. Like I have this little secret. Yeah. A lot of people don't even know about it. They didn't really want to get into it and have the conversation with a bunch of near strangers every day. And so it was good. And I like to tease my daughter now, because she's always been really interested in medicine. I'd bring my kids to work with me when they were little, and we'd go and make rounds like on the weekends and stuff. And she always really liked it a lot. They both did, but she always said that she was going to be a doctor too. And I didn't really read too much into it, especially when she was a young kid. But actually, she's applying for orthopedic surgery residency right now. So go figure. Oh, that one worked out. So I feel really happy that it turned out like it did. And I like to joke that she got her start in utero.
Yeah. It really works well when you've got clearly both of you on the same page, you and your husband at the time. It doesn't work. It's not as romantic when I got to my wife in like May 2009 and say, right, we're going to get pregnant this week. It fits my schedule. That doesn't work quite so well.
I'm grossing out at this point. I think letting fate decide is a nice, nice way around. So Heather, do you feel like we're getting better at that? Getting better at accommodating families, not just women, but fathers as well, at the time of pregnancy and childbirth?
I think so. I actually think the United States has been behind on a lot of this stuff, and you were alluding to that just a few minutes ago, if I was hearing you correctly, and I would agree. And it seems like maybe the last 5 to 10 years it's been somewhat better, but it's tricky because a lot of it is lip service. People really want to do the right thing, I think, and they say like, "Oh yeah, we do this and we support that," but then when push comes to shove and it really happens, it's never terribly convenient, and there's not a perfect way to do this, but I see it as, we all have our lives and we have to take care of ourselves and each other. And these are goals that many people are going to have, many couples are going to have, families in a traditional sense or in a non-traditional sense. And so having some level of respect for that and that expectation that it's going to happen. And so trying to deal with it. I think there's ways to create, standards in terms of, there's amount of leave that's allowed and considered appropriate. If we can agree on those things, and that's good because then you have some framework to work in. And whether it's a residency program or various hospital systems, it seems to be certainly more common and much better tolerated. But it's far from perfect. On the other side of things, it's interesting because that's a topic that I get asked about a lot privately. By men and women who are trying to figure out, hey, what's the right timing? Do you think if we did this, what do you think about it? And I always tell them, like, I'm happy to give you my 2 cents, but your life, your relationship is yours. And what you want it to be is yours. And so you have to make it the best you can. But keep this in mind. One is going to be a lot more exhausting than you think. And a lot more tired and a lot less glamorous than you think. Yet the benefits I think are wonderful, and to have a family, to reproduce, and to have that opportunity is a lovely thing. The second thing is that you can't be excellent at everything. There simply are not enough hours in the day, and so something's got to give. And so you're going to have to figure out, well, do I really want to spend a lot of time in research as well as developing my clinical practice, or do I really feel I can do all of these things? Because there are not enough hours in the day, so you have to decide what to say no to, what to cut back on. And I think for women, and to a lesser extent men, that's difficult because many of them with aspirations for academic careers aren't able to put in the time to get involved in research consortiums and doing a lot of writing and presenting, particularly with travel. When you're traveling to teach and to present, it does take up a lot of extra time. And so it's something that you have to decide, because it does change your career trajectory a little bit, whether it's intentional or not. And so I don't mean to sound creepy about it, but I think it's just the reality. It's something has to give if you're going to do all of those things.
I must say, I'm surprised they ask you for advice, because you say basically find the craziest, busiest time in your career and do it then. So they should ask somebody else.
And then just pile more stuff on top of yourself.
And get a puppy while you're there.
Yeah.
But actually, life doesn't get simpler as you get older, does it? No. It doesn't get less busy. You think it's going to. If I just get over this next hurdle, then life will suddenly become easier.
And the thing is,
it actually just opens up a whole new tree of opportunities.
But also, work is always there. Work is always there, and it's always going to be there until you decide you don't want it there. And so, family, you've got to just prioritize.
Yeah.
Right.
And it's a lot easier for men than for a lot of women. There's a lot disproportionate pressure placed on women, which I'm aware of.
We're going to have to do this sooner or later, so let's get on with it. We're going to lance the boil. Heather, you are hugely you're diversely published across a wide range of themes, but the one that you are constantly associated with is this thing called early appropriate care, and I'll talk about that in just a second. But just for the benefit of our listening audience, there's always been a lot of controversy around how you manage patients who have multiple injuries. So they might have a head injury, chest injury, and multiple orthopedic injuries, broken this, broken femur, broken pelvis, etc. And throughout the 1990s actually back in the 80s, there was often a trend for just fixing as many of the fractures as possible. So patients would go to theatre, they'd have multiple fractures fixed. And what we noticed, or what was reported, was that many patients ended up having severe complications, systemic complications like ARDS, their lungs would pack up, or they get multiple organ dysfunction, or they'd get systemic inflammatory response syndrome. And so during the 1990s, there was a kind of a pushback against that into damage control resuscitation. That's the era that we grew up in. Giannudis and Pape brought out a number of articles saying that we should be going easy on these patients, and particularly we were very, very focused around people's femurs. It was all about femur fractures. And so we were... We knew that we should be fixing people's femurs, but there was a tendency to put them in external fixators. And then as time went on, we were showing that actually early femoral nailing was strong as well. And there was a lot of controversy, but the focus was always around people with femur fractures. And really, it was your articles that really expanded that to being not just femurs, but pelvis and acetabulum, and indeed spine as well, kind of axial fractures, if you like. You've done so much other stuff. Like, for example, we had a residence annual training day a few months back, and you very kindly came and spoke to us over Zoom, and you gave a great talk about early appropriate care. This series of articles you did over between 2013 and 16, and it was a great talk, but I could sort of like sense your inner voice of, oh my God, I'm so bored of giving this talk. Do you ever feel typecast? Do you ever feel that, it's just like, I wish I could talk about something else for a change?
Well, it's kind of funny. Yes and no. I think that after doing that and getting invited and having the good fortune to have a lot of interest and a lot of people wanted to argue and get into it for a couple of years, admittedly, I did get a little bit burned out. I was looking to try to speak on other topics just to mix it up, to keep it fresh. But not so much now. Now I look back on it, it's like, it's a little piece of history and my pathway and the team that I worked with that helped to develop protocols and things. I feel like we have a little piece of orthopedic history that we did at our center, and that other people have been able to apply in some ways to their work as well. So that's fun. It's a good stretch. But it's interesting to look back on, because things never turn out exactly like you think they will, and they always take 3 or 4 times longer, or even longer than that, than you think they will. So it's an interesting thing.
But then as well as having orthopedic history, you have also impacted positively tens or hundreds of thousands of lives, and so there must be a real kind of pride in knowing that what you've done has really impacted people around the world.
Well, I feel like that's a really profound thing. Wow, I'm not I haven't really thought about it from that angle, but I think that's why we do what we do. We're surgeons because we like to fix things. And so I'm a surgeon at heart. I'm a problem solver, and I'm a team-based surgeon. And so for me, it's very natural to want to look at problems that affect the team and how can we work better as a team to take better care of people. Because if we take better care of people and we work in a teaching setting, so our local environment of residents, students, fellows, people coming through are going to see that, and they're going to hopefully make the system even better by tweaking it and having critical conversations. Then that spills out into all of the people that they touch. And I always felt like, wow, it's very cool that we work in this setting, because we can try to make improvements, and then those improvements are going to ripple away, and other people are going to do the same thing. And that's how we're all going to continue to grow as individuals, but as a profession as a whole. And so the EAC thing was fun because it brought together people from a lot of different disciplines. And so some of the colleagues that you hang around with at night and on the weekends when most other people don't really want to be there, and we're doing some really important cases, and we're learning from each other, and we're talking about it, and we sat down to think about how we could come up with a way to standardize resuscitation so that we could agree and we could set standards. Because it's a funny thing. When I was a resident, I mentioned earlier, the trauma at the University of Wisconsin was very busy. We were doing a lot of trauma. I feel like the quality of the work was pretty good. But it's fascinating because there was always a lot of emphasis on getting the hip fractures to the OR, getting the femurs nailed. And that was a big thing in the mid and late 90s when I was a resident. And then when I went to Seattle, it was like that. And there was more volume. But what I noticed right away is that a lot of the patients with pelvis and acetabular fractures, they would all be treated usually the next day or even that day that they came in, depending on the time of the day and the nature of their injury. And they were doing better because during residency, many of those injuries, the patients would wait for 3, 4, 5 days or more.
On
And there were a
traction.
lot of
Yeah.
pulmonary complications. Yeah. And so it was obvious to me, like that can't be a good thing. And then you start the wheels turning and go, well, why are we emphasizing that all of these people with ephemeral shaft fractures should be going to the OR, but we're letting these other people just sit there for a couple of days? I think that doesn't make any sense. It's the same burden to the body. So you
Mm.
start asking the question and, talking with like Chip Rout, who is one of my mentors when I was a fellow. And he was, very much in line of getting patients fixed early because he recognized the value in that. And we talked about the handful of old papers that were out at the time that suggested that that was really a good thing because there was very little written about it. And it's certainly not very much in practice because there weren't that many people who could take care of those injuries. And so they're not always available every day, or the
Yeah,
patients maybe
absolutely.
didn't even find their way to a hospital or to a surgeon in that time frame. But I kind of started thinking like, we need to strive for better. So that was in the back of my mind as I went into practice. And when I came to practice in Cleveland, I just started doing it that way. And one of my partners, Brendan Patterson, was also of that mindset. And he had trained in Seattle and he recognized it too. And so it's occasionally out of just purely convenience or exhaustion or whatever the circumstances gave, the patients wouldn't necessarily get fixed within that, say, day one, day two
Mm.
window. There would be some delay. Other people in the group tended to let the patients lay in traction with an acetabulum in particular, like, well, have some time on Thursday afternoon, so let's just get her ready for then. And then occasionally they'd get pneumonia. They
Mm.
die.
Yeah.
And it really bothered me. And I kind of kept saying, as a system, we need to do better because there's enough of us that every day somebody could take care of these people. And I don't think this would happen. But I was getting some pushback even from within my own group. And so then we said, well, maybe we should study this. If we were able to look at a sample of our own work, because there's thousands of patients over the last several years that have high energy injuries that fall into one of these categories, it would be a good thing. So I have to bring into picture my other colleague and friend, Tim Moore. And Tim is the director of spine trauma in Cleveland, and he was actually a resident when I first started in practice, and then he did his spine fellowship, and he came back to work at MetroHealth like a couple of years after I got there, and so he was all about wanting to take care of every broken neck and broken back in Northern Ohio, and he was going to do it, and he was going to do it right away as soon as it was safe for them to go to the OR. And his work is amazing. He's an incredibly talented surgeon, but he's an even better person. And he holds himself to this standard of really wanting to get these people fixed, potentially for neurological benefit, if there's cord or roots, nerves at risk, but also because he recognized the value of early fixation and how it applies to the spine, the axial skeleton, similar to pelvic ring or a mechanically unstable acetabulum. And so it's physiologically placing a similar burden on the patients. The spine thing is tough though, because those surgeries maybe even harder to come by depending on your institution. If you
Mm.
can't find an acetabular surgeon, are you going to find somebody who's going to do, a lumbar corpectomy and fusion on a
Yeah.
Sunday?
Yeah.
Maybe not. And so we were doing things that were very unusual at the time, but it was the right group of people to be able to look at the work we were doing and then to find a mathematician who could work with us to develop some models to figure out when is it safe to do this. Because there was a lot of pushback out of convenience and then a lot of pushback of, well, your data don't necessarily show that it's better. They suggest that, but it's very difficult to get your arms around. So that's kind of how that all came to be. And it's fun to look back and think, we had a lot of the right people in the right circumstances and the patient volume and experience to be able to analyze it and to share, to grow from it.
So my question to you now on the early appropriate care front, was that your term, Heather, early appropriate care? You came up with that?
Yeah, actually, I did, and it's funny because I'm really bad at coming up with
Catchy
acronyms or
names.
titles for papers. It's just not something I've ever been any good at. And
Yeah.
so, one afternoon, I was chatting with Brendan Patterson in his office, and we had kind of brainstormed around this idea of finding someone who could mathematically model the resuscitation path. And, we call it, and we had this vision of there's got to be a time point where the body is ready. And, it's based on some level of the physiology. What is the response to it? So we could figure that out. We could say that it has to be different than early total care. And we don't want to be anti-damage control. We need to come up with something else. And so that was where early appropriate care came from. And at first I was like, early appropriate care. And he's like, EAC. And I was like,
yeah, we found it.
I'm not feeling it. And so we kind of couldn't think of anything better. So we went with it. And there you have it, early appropriate care. Because it's early and it's appropriate. And appropriate might be definitive fixation, or it might be damage control. It could be either. It just depends on where that patient is at, and what's their injury burden, what are their other factors that are playing into the situation. Maybe it's even an element of surgeon or availability, because that happens still, depending on where you work. And so it's a way to try to encompass all of those things, but the emphasis on early doing something, whether it's provisional or definitive, it would be an appropriate intervention for that person.
Great. And where do we go from here, Heather? Because we're now at a situation where we've got your articles and people have gone away and they've applied these protocols to their practice, and it definitely works in the vast majority of patients. But there's still going to be some patients where we get the decision making quite slightly wrong, or we're too aggressive or not aggressive enough. Where do we go next with early appropriate care, damage control, orthopedics? Where do we, should we be looking to machine learning or looking at massive databases? Where do you think the next step is?
I think the element around the massive databases and machine learning is problematic in this area, because the way that the computers are based to learn isn't necessarily based on the things that we deem to be most important. So that's going to be problematic. But I think that the pieces that could use further attention, say in the next 5 to 10 years, would be around issues of tweaking the coagulopathic state. And so now we can do more focus through, thumb tag and that sort of thing. So nuancing the type of resuscitation to include the coagulopathic elements. When we made the EAC protocol, we actually wanted to make it as simple as possible so that it could be widely applied to all of the injuries that we've mentioned, but also to people of different ages and backgrounds. And so it's easy to remember and kind of adhere to. And so it has that universality, but there are nuances. And so I don't know that this will be in the next 5, maybe in 10 years, a genetic piece, because there's differences genetically in terms of how someone's body has an inflammation and responds to injury with an inflammatory profile. And so having a better understanding of that is something that I think is really fascinating. And there may be opportunities to say, well, this person needs a little bit higher level of resuscitation because they have this genetic type. And so I think that that's another area, and probably an element of age. So the age, how does that factor in? Well, it's the the pump doesn't work as well, the kidneys don't work as well, so everything it needs to be modulated a little bit. In our own data, the samples just weren't large enough to really flush that out, and we tried to look at elderly people or people with cardiac disease, and it's difficult because many of those things you don't necessarily know, and so it's probably way underdiagnosed, and it's in the grab bag of whoever shows up at the trauma bay that you're taking care of these people. But these other elements of their medical background are not well enough understood. So I think that personalizing the EAC pathway through attention to injury specifics and underlying patient comorbidities is going to be the way that we need to go in the future to do better about what we're doing. And then the last piece I wanted to say is that a lot of institutions and a lot of individuals haven't been able to adopt things like this because they still lack the system support. Maybe they're, again, the only person or one of two people who do acetabular surgery in a large geographical area. And so it's not feasible. So we need to have people trained up to manage these injuries, or if they can't, to have transport mechanisms in place so a patient can get to the center that they need to be at. I feel like in the UK, you guys have done a much better job of, first of all, sharing data, to figure out who should be doing what and where, and helping patients get to the center and to the care that they need in a timely fashion. And there's too much money involved in the United States that hasn't happened. And so it's not been nationally mandated. And I don't think it will be, but I wish in some ways it were, through, say, the American College of Surgeons or other means, to standardize this a little bit more effectively, because we would be taking better care of people.
What is the next piece of research that needs to be done for early appropriate care? Is it an RCT? Is it a massive database? Is it what needs doing?
I think we need massive prospective data collection and standardized pathways. And so if people are using EAC or saying, well, we're going to use EAC, but we're going to adjust it for these means going forward, I think having large centers in place that are routinely collecting these data prospectively. And a lot of the data is being collected through trauma registries, but it's not organized or intentional for these purposes. Now, there's a group that Aline Bulger and Jim Fickey put together. They got a grant through the Department of Defense of the United States. It's a National Trauma Research Action Plan, I want to say it's called. But they kind of involved a lot of trauma surgeons from all different disciplines to look at the status of care in the world and in the United States, and then to say, well, what areas warrant more funding, more research attention, more infrastructure, so we can make that investment in the next several years. And I think that that's good, because it's going to encourage more dialogue, more getting away from people trying to just be one person, one group doing the whole thing, but to working together, communicating, and agreeing that these are, 3 items that should be at the top of our agenda in the next decade to solve. And so then we can say, well, we're going to do this. We're going to prospectively look at this, and let's agree that we're not exactly sure. There's 3 different opinions on how this might play out, but we agree that this is an important issue and we need to study it. So let's commit to that. And I think that culture is in place. And so now it's just a matter of time to help bring it to fruition. It's moving slowly, but I'm optimistic.
Do you ever think there's going to be a national trauma registry in the US?
I think there will be. The problem has been that it's just a matter of mandating it. And the American College of Surgeons could do this, but classically they've been kind of impeded by the fact that they verify trauma centers, and so they set standards. Yet there's certain states who say, well, in our state, we're not going to use that standard. We're just going to have our own. Right. So we're going to do this. So people can opt out.
It's like grading your own paper, isn't it?
We need to agree, if we're going to be part of the American College of Surgeons, that we all opt in, because we agree that as a nation, we should be the best that we can be. And so if your state is the only one or one of 8 that decide not to do this, why are you better than everybody else? And if you're better than everybody else, then come on board and show us how you're better.
Show us how damn good you
are. We can all
are.
be better together. So I think we need leadership that's going to have some teeth in it. And the issue is that the ACS gets a lot of money because people pay to have their sites verified, so they can hang their shingle on the door that says they're a level 1 or level 2 trauma center. And so there's all these competing interests at play. But if we were able to get it back down to, let's take the best care of patients that we can, I think most physicians would be on board with that. And economically, it's generally a good thing too. The problem is there's these little fiefdoms that have cropped up that would need to get broken down. So we need strong leaders to pull the field in that direction.
Yep. And can I ask, without being controversial, is that something the OTA gets involved with?
It's interesting, a little bit. We're a much smaller organization than the American College of Surgeons, and the ACS is just in the United States, although there's some influence in other countries too. The Orthopaedic Trauma Association is mostly North American. About 15% of our membership is worldwide, and the idea is to appeal to a worldwide audience with trauma protocols, exchanging, educational ideas, research ideas, all that sort of thing. But in terms of just trauma center verification, trauma protocols, the OTA works with the ACS. There's called a Committee on Trauma. And so we have representatives that sit there and they meet. And it's very bureaucratic and it's very slow going. But I think that that's going to be one of the inroads to making stuff like this happen. And also, maybe as a segue, one of the other topics that I'm really passionate about is the whole aspect of recovery after trauma and encompassing the psychosocial elements of it. And that's a place that we're working with right now, because there's some ACS leaders who recognize the value of that. And can we create standards as part of the trauma center verification process that you need to have elements of psychosocial programming in place at your hospital?
That's huge.
Because I mean, that's one of the pieces that you've been talking about a lot lately, particularly as OTA president, has really resonated with me and a lot of surgeons in the UK, which is around patients' recovery after trauma. Because as orthopedic surgeons, we're really guilty of focusing on what the post-operative X-rays look like, and we're very, very radiological based, and we do focus on patients receiving physical therapy. But recovery after trauma is so much more than a few sessions of physical therapy and having a straight leg, isn't it?
Oh, absolutely. And it's a funny thing, because we've all been there in the clinic where you're in the room and you go, okay, well, your tibia plafond is healed and it's ready to walk on, and that's fine. And they come back 3 months later and the person is just sitting there crying in your office.
Why are you crying?
Oh,
The
what's
X-ray
going on? Why are you crying?
The X-ray looks great.
I'm like 40 minutes behind. I can't stop now. But seriously, I mean, this happens, and then we don't necessarily have the time at that time and place because we're behind, we're overbooked and overextended. We're so focused on, bone broke, eye fix, X-ray says it's healed, go walk. Okay, see you, back to work. But we're taking care of people. And people come with all kinds of issues that predate their injury, and then many new ones after their injury. And how do we help them to heal and be functioning members of society really requires that we go beyond our training. And so I think that we as trauma surgeons are not trained to do this. We recognize that there's a problem, but we also recognize, like, whoa, I can't deal with that. I don't know how. I don't have resources. I don't have time.
Right.
So I just don't do it. It's easier to just do nothing and then move to the next patient in the next room. And that, I think, happens a lot, which is sort of sad. I'm guilty of that as well. But recognizing that the person's not going to really get well, they could be healed and have an identical X-ray and identical appearance of their leg to the person down the hallway, yet they can be functioning completely differently because of their social circumstances, their mental health, whatever the case may be.
Absolutely.
And so that bothered me quite a lot those first years when I was in practice, because I felt like, all right, I'm getting more comfortable with surgery. I feel really good about certain types of injuries. They're fun to take care of, yet some of my patients just aren't doing well, but I don't feel like it's something that I control. And then you realize, well, there are ways that you can control it if you can get other people on your team. And so it's a matter of building the team to have other resources, other professionals who know how to identify and treat some of these issues that we've ignored in large part.
Yeah. And we're talking about things like psychiatric symptoms, as you say, post-traumatic stress disorder, but also things like sexual dysfunction, threats of domestic violence, stuff that
substance abuse,
stuff that we're not very good at asking about because it can feel a bit confrontational or invasive. What do you think good inclusive after trauma care setup should look like? How do we pick these things up? Okay, maybe we're not great as orthopedic surgeons, so how do we do it? Are we handing out questionnaires in the waiting room as a screening tool, or can we go further than that?
Well, I think having some screening mechanisms in place is a good way to start. But it's crazy because it's such a daunting proposition that a lot of my colleagues will say, like, wow, it's great that you're working on this, but I can't do that because I'm just one person. It's like completely overwhelming. Maybe just pick one thing if it's only you, and decide, well, I'm going to give out all my patients at their first post-hospital visit are going to get a PCL-5 questionnaire. It's a little one-pager. It takes about a few minutes to fill out. It's highly sensitive for PTSD. And we use that in our clinic now. We've been doing it for several years. And we even added a question at the bottom that just says, did you think you would die during this injury? Yes or no? That's the simplest one of all. If people say yes, they basically already have PTSD.
Yeah,
and we were able to study this and write about it. I mean, it sort of makes sense, right? Anybody that says it, you'd be like, this person's in a bad way. I got to figure out who I can call to connect them with because they need help. But those are really simple things. Maybe just a little screening that you can do, even if the rest of your system doesn't want to do it. And maybe there's a nurse or a case manager, somebody who's excited about this concept that is part of your team already. And you go, hey, well, can you give out these surveys to everybody in all the trauma clinics? And they're really easy to score. And then you realize, like, wow, over a quarter of our patients are screening positive for PTSD.
Yeah.
Now what? What are we going to do? Because we got to have people who we can send them to. So you build from there. But I think having a couple screening things in place, pretty easy to do. Most trauma centers, even worldwide, have trauma care coordinators in place that do like alcohol screens and substance abuse screens. We do tox screens when patients come in. So you having some mechanism that some of these things that are either in place or would be very easy to add can pick up a lot of things as a starting point. And then having something that you do with that information. Don't just collect the information and go like, now I feel even worse because I know all these people have this problem, and then they're just sitting there and haven't done anything about it. So pick out something simple.
That's certainly true of things like substance abuse and domestic violence and things. But it's a lot of the psychiatric stuff like doesn't happen in hospital. Actually, you're on a bit of a psychological high while you're in hospital because you've been cured, you've been fixed, you made it, you survived. It's actually after you go home that you get that slump coming in, and you start getting very depressed, very reclusive, and all the rest of it. One of the things I wanted to ask, two of the terms that you use a lot in your discourses is self-efficacy and recidivism. Could you just explain what those are?
Sure. So recidivism has to deal with recurrent behavior. And so in trauma recidivism, we think of trauma recidivists as people who keep coming back with related injury events. Maybe they're completely different mechanisms, but they're related to this person's polysubstance abuse at baseline. And so they're a trauma recidivist because they continue to hurt themselves and potentially other people because they're imbibing and they're not taking good care of themselves. They're making poor decisions. Maybe they're recidivist because they're in an interpersonal, domestic violence situation. And so they've come in with a couple of different injuries. And so trauma recidivism is really, unfortunately, it's pretty pervasive. It's more than you realize unless you start looking for it. And the first time that we started looking forward at the MetroHealth system was over 10 years ago, and we realized that almost 20% of our patients were coming back within 2.5 years with a completely different mechanism of injury or an unrelated trauma episode. So that's pretty dismal. But it's patients in high-risk groups, those with a history of substance abuse, those with underlying mental illness, those with an unstable social situation. So people who have risk factors and certain mechanisms, penetrating trauma, particularly ballistic trauma, which is quite common, unfortunately, in the United States. The recidivism rate is very high because the reasons why that's happening are not being attended to. We're saying, oh, you've got a gunshot to your femur. We can put a nail in that. You can walk on it tomorrow. I'll see you. And then they're back again with a gunshot to the other leg in 1 year. So that's not really good. And it's super common. So that's recidivism. And it's a way that we're trying to measure program effectiveness a little bit. If we can get the recidivism rate to go down, then we know that we're changing behaviors. So that's a good thing. Self-efficacy is an important term because what it is it's a function of someone's belief in themselves, and whether it's them or the people around them as a support system, that they can actually have a positive change, that they have the ability to set a goal, to solve a problem, to make improvements. And there's some people sadly have little or no self-efficacy. They have no resilience, no ability to do that. Can we change that? Well, I believe we can by providing them with a support system. If they have no individuals in their lives as a functioning support system, or maybe they have a dysfunctional support system in place, it's even worse, perhaps. Maybe the system, whether it's the government, the hospital, social support system, volunteers can work together to build some structure for that person to help them to realize that they can actually step up and have a better life. I think most people want it, but they don't necessarily realize that it's even possible.
Yeah.
And it's crazy because it's like peeling an onion. You start asking a question like, well, what about this? If we had a group, I could set up for you to meet with this rehab psychologist. they'll say like, well, no, I can't do that because I don't have a car. Well, could you get a ride? Well, I can't really get a ride because then I'd have to call my boyfriend. But whenever he's drinking, then he beats me. So it's like,
Yeah.
oh, okay, well, I don't really want to go there
Yeah.
either. And how do we get you to where you need to be? And so it is complicated, but those are a couple of the key pieces that once we understand as surgeons, and it's common sense, really. I mean, it makes sense. We're around it a lot. It's just that I think most physicians are so busy and so having so much difficulty just keeping up with their own lives and their own practices. When you start to throw these other things into the equation, they see it as it's insurmountable. I can't take that on because I'm just one person, or we're
Yeah.
just one division in this whole system. And so, without leadership that's drawing attention to these things, educating about it, and kind of creating framework and structure for these changes to happen, or perhaps to be mandated, I don't think it's going to change, at least not quickly.
It also kind of does disproportionately affect the traumatologist, doesn't it? It's not going to affect this. It's not going to affect the sports guy to anywhere in the same degree.
For sure. And I think that that's a piece of job satisfaction longer term.
Yeah.
You know, it kind of wears
Agreed.
you out. I know when Metric did this study on trauma collaborative care, you know, they before the study, which was a series of interventions, including a recovery coach, a peer mentorship program, educational materials, so a really robust recovery type program installed at some hospitals, and then a bunch of control hospitals that had little or no programming, whatever they were using at the beginning, which was usually nothing. Compared the physicians caring for these patients at both hospitals, and the physicians at the hospitals with no resources realized like there was generally this malaise around it.
Yeah.
You know, I can't help. I know something needs to be done. I don't know how to do it. We have no resources here. I feel kind of unhappy about it. It's a dissatisfaction.
Yeah.
Yet the patients are more satisfied at places where there's resources, and so are the physicians.
But it's funny because you use the word recidivism, and you know, we often call them repeat offenders. And I think
Frequent flyers.
frequent flyers.
Yeah.
And if you don't have the resources, that's going to lead to burnout, because there must come a point you go, well, sod this, because every time I fix one, two come back, and that's where you can feel like you're fighting the uphill battle.
And violence prevention is something that's really gaining traction in the UK as well. We had Martin Griffiths, who's like the national czar for that, speaking to us a few months back.
Podcast, yeah.
Great.
Where was your position on violence reduction?
Yeah, I think that that's a tricky one, because as soon as you bring it up, a lot of people want to go into their political mindset and go like, okay,
right.
which camp are you in? And it's just, you know what, this isn't about politics. This is about public health. It's about trying to help our society to be well. And we're not going to be well if there's a whole group of people that are hurting each other and, you know, spilling over economically. We're having to provide for them, but it's like you can't just write off a whole segment of your society. And these issues kind of roll over into other groups as well. It's easy to say, oh, it's just this group or that group, and it's really not the case either. These are common themes, and so I think that as a society we need to draw attention to it. Then one of the first things is to become apolitical. Ballistic violence, gun violence is a big problem in the United States, and
Yeah.
there's just, I mean, ranging from one extreme, like, well, if we had no guns, then this wouldn't happen. We just need gun control. It's like, well, okay, that's kind of oversimplifying, because
Yeah.
people who have difficulty purchasing a gun, or if there's no guns allowed, there's still going to be guns, or
Yeah.
people are going to hurt themselves other ways. So, although that's one thing, let's not get too hung up on it versus, well, why are people hurting each other? Why is there violence? And why do people keep returning to violence, even if they know they almost died, but they go back to it?
Yeah.
Because they don't see a viable alternative. So what are the alternatives? How do we get to where we are? And a lot of this has to do with relationships and structures. So having some investment around education, safe places to live, you know, social determinants of health, things like basic education, home situation, upbringing. And it's tricky because there's, again, so many factors that weigh into this.
Yeah.
Most people say like, well, it's easy for me to say that I oppose, you know, gun ownership because I'm against gun violence. It's like, okay, well, I oppose car violence, but we use automobiles to get around. We use engines to find our way. So it's just not that simple to write it off. And I think that in order to even have these conversations, we need to agree to not be politically trying to attack the other party. We
Yeah.
have to be able to look at it from a social public health type perspective in order
Yeah.
to make any headway on this at all.
Understood.
And
But
I've
it's sad because it's growing quickly and in the wrong direction. I
Yeah.
think COVID really accelerated it.
And it's interesting to hear that. I mean, I fully understand why you need to be apolitical to get buy-in from everyone. It is interesting because Cleveland, where we work, are quite similarly deprived areas in places. We have except we don't have much gun violence. Ours are knives. We're just lucky that we don't have a knife lobby.
Heather, how do you fit it all in? How do you fit it all in? What do you do with all your email traffic, your WhatsApps, your notifications flying in all the time?
Please tell me.
People asking for podcasts, people like meetings, and you've got to be an orthopedic surgeon, and you've got to be a researcher, and you are OTA president. How do you fit it all in?
I think that I don't have a perfect answer for that. And I've been perpetually overextended now for decades. And so I kind of learned to live like that.
I respect that.
I would say that one thing that I did make a big change on probably 15 to 20 years ago is I realized like, wow, this isn't going to be sustainable. Like I'm not taking good care of myself. And so then if I'm not taking good care of myself, like maybe I'm not sleeping enough, or I'm not getting any regular exercise, or whatever elements of my life are important to me, which happen to be, maybe some time with my husband, some relationships, sometimes away from medicine, then I'm not a healthy person. I'm not going to be able to function at my best when I'm there. And it's counterintuitive because we've all been there when you go like, well, I have to get these 7 things done. And if I don't get those done, then I'm going to be in a worse way. So I just won't sleep as much, or I'm not going to work out at all for the next few weeks until I can get this taken care of.
Yeah.
It's not a good answer because then you're completely out of whack. And so I made some very specific intentional efforts to change things like that, the destructive behaviors that I was developing, to take better care of myself and to protect time for me to exercise, to do things with other people, to just reprioritize, to make sure that I wasn't losing track of who I was at my core, so that I could really enjoy and perform well at these other things that I am passionate about. I love being a trauma surgeon, and I enjoy the academic piece and the research, but you have to put up some barriers on it. And everybody has their own unique set of barriers and give and take, and it'll change over time. But I think recognizing what those are and having that is good. I think for me too, my husband and I have an amazing relationship. We're both very driven people, and we have a lot of commonality in terms of what we do, in terms of his science and his other creative writing and work that he does. And we don't have a lot of time that we spend together, but when we do, it's really good time and it's very nurturing. And so that's been extremely important to me in the long haul. And I think too that I've been blessed to have children and to have a family, because when they were younger, would come home at night, even if I was really exhausted, it's like you get this little glimpse as to like, yes, this is important. And maybe it's bad or something didn't go well at school or who knows what, because it's life. These ups and downs happen. But it was perspective. And it was the idea that I'm doing something beyond just my professional work that's really, really important, to take care of other people and to bring up children and adults in our world to replace ourselves and help them to be more successful than we could be.
Yeah. And that's certainly the goal, isn't it? For your kids to do better than you ever did.
Yeah.
And set them up
exactly.
right. So just a couple of things to round us off. If you were to give an advice to a young Heather Vallier, what would you tell her?
I would go back to what I was just saying a minute ago, and that is that, you know what, you have to, I think it's that conflict of living every day like there's no tomorrow, yet planning for the future. So you need to do those things, but while you're doing it, don't lose track of who you are. Remember who you are, why you're doing this. What do you enjoy? Taking care of people. What are you passionate about? Is it recovery? Is it a basic science piece of what you do? What makes you tick? And make sure that you keep those things in mind, but take care of yourself better. I think I could have done better the first several years, for myself, a balance of those things. But maybe that's what kind of keeps me going. I don't know. I don't know what the perfect answer is, but for me, if I were to give myself advice, it would be a little bit more of that. The problem is that I remember people saying that, but I always kind of look like, yeah, 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 yeah. Okay, I gotta go. I gotta go. I'm busy.
I got stuff to do.
Yeah.
Yeah.
So I'm not gonna listen necessarily, but it's important. It really is. On the way flip side of it, this kind of drives me crazy too, because I'm a big proponent of well-being and moral injury and avoiding burnout and all that stuff. But you have to work really hard what we're doing,
Yeah.
and you need to immerse yourself and do thousands of cases to become really good at it.
Yeah.
Yeah.
So you have to figure out with that tension. And maybe I give a lot of advice to medical students. I help a lot at the medical school. There's a lot of people that their surgery is just not a good career for them because they're not interested in that, or they're not capable or committed to wanting to do that. And that's all right. They're going to do other neat things. But I think they should know that up front. It just takes a lot of time.
But do you have to be that uber type A person to be successful in orthopedics? Can you have people who are a bit more type B, a little bit more laid back, and yet they can still be good orthopedic surgeons? Are they mutually exclusive?
It's a gradient. Yeah, it's a gradient, and too much of either of those things isn't good. Because if you were too laid back, you probably wouldn't have the wherewithal to really push yourself to take exceptional care of people. Yet if you're too type A, you're going to really be sacrificing yourself, and giving yourself a heart attack.
Yeah.
And so somewhere in between there is that tension of really challenging yourself to work hard, but to recognize, like, you know what, that case didn't go as well as I thought it could. Is there anything I can learn from it that I can improve upon? Think about it for a few minutes or several minutes or however long you need, and then put it away. And let it go, and you move on, and you learn, and you live, and you grow. You don't fester
Yeah.
and you don't beat yourself up for too long, because you gotta survive and get on to the next person. So I think that it's a mix of A and B is probably the best.
If you had 8 weeks of enforced leave away from anything remotely orthopedic, you're not allowed to touch any bones or do anything to do with bones, what would you do with the time?
Yeah, that's a really, really cool one. And I think I would do some of the things that I already like to do because I know that they're very rejuvenating for me. And it would be, I would take a long trip or maybe a couple of trips to some of the national parks, maybe head to some of the ones that I haven't been to in a while, like Yosemite or Kings Canyon in California, maybe Glacier National Park. But go and just spend some time outdoors, like really away from people,
Off the
disconnect
grid.
from the internet. Exactly. Yeah. And just be away in nature and do some hiking, really work up a good sweat, climb a mountain, enjoy the scenery, the fresh air, and have some time to think, and experience the world that way. I think also I would spend a little bit of the time doing some gardening and some yard work. I happen to really enjoy that. There's something that is very refreshing to me, and I do a lot of that when the weather is better here in Ohio. Vegetable gardening, flower gardening, and it's kind of like little projects. You can try things, and some of them don't turn out at all, or they don't work that well, but others do, and it's kind of fun. Grow some vegetables, and so I would putz around with that a little bit too, because again, it clears my head. And it allows me to do something a little bit physical, and you can see the rewards from it.
Awesome. Pete, what would you do if you had 2 months off?
Well, I was just thinking, we have a local village show every Easter and every summer where they've got, I mean, it's basically people showing off their flowers and stuff, but it's a competition. So you've got the funniest looking carrot, the strangest looking vegetable, the largest pumpkin, the heaviest marrow competition. Okay. Are you one for growing giant vegetables, Heather?
Yeah, they never turn out that big.
Yeah.
I got a pumpkin that was pretty good sized last year.
Pete sounds
it was funny because in the pumpkin patch, they weren't growing all that well. They were really little, and one of them got eaten, and there were there's a deer and other animals that kind of come by and harass us. But some pumpkin seeds in this mulch pile had taken root and a plant was growing in there, and this giant pumpkin grew out. And it was like completely unattended, but I still take partial credit for it.
Yeah. Well, I love hearing Pete's stories. He lives in this quaint little village. I think it's like stuck in 1920s England.
No one has TVs.
No TVs. Morris men dancing around a pole.
Really good though. You still got to see Happy Days. You know, you could just see it once in a while.
I just saw it. I just saw it 20 years late.
Yeah. I'm gonna get you the box set. Now the last question. I've never been to the OTA. It's in Florida this year. Is it worth it?
Yes, it's definitely worth it. Well, first of all, this year, because, you know, last year we did have an in-person meeting, but it was a much smaller attendance. And so it's a really exciting time because it's an international group. About 15 to 20% of people come from outside of North America. And so it's a widely attended meeting. And there's a lot of intellectual exchange. There's a lot of collegiality and socializing that goes on, catching up with old friends, making new friends, exchanging ideas. And I can think back to other OTAs, little conversations that you have around having some beers with friends at night. And then 3 years later, there's a really cool research project that came to fruition because of that conversation. So there's all kinds of really fun stuff, educational stuff, professional advancement that goes on there. And I think that the more people that attend the OTA and the more people that become members and become engaged within the OTA, it's a better society. And our society is having impact around the world. We're really having more of a global presence. And that's the goal of the group, or one of the goals of the group over the coming years, is to have more standardized educational resources and more humanitarian presence globally to improve the level of care that we're provided, particularly in underdeveloped areas.
Okay, well, I look forward to it. Well, I'll come and say hello in person.
Yeah, that'd be great.
Yeah. And I won't turn up 15 minutes late for your keynote like Pete did.
That's all right. You didn't miss anything you didn't know.
Heather, thank you very much for joining us today. It's been a real privilege.
This has been a lot of fun. Thank you so much for doing this, and congratulations on a successful podcast. Very good.
It's been an absolute pleasure. Generally, I'm honored to have met you, so thank you.
Heather, it's been a real pleasure. Thank you so much.
Seeing you in Tampa.
I'm definitely there, and I'll drag Cash along as well, because it is an awesome meeting.
Brilliant.
Sounds
thank you.
Good.
Okay,
Take care, you guys.
Bye.
Thanks a lot.
Cheers, Heather.
Bye-bye.
Thanks so much.
Nice. Hey, it's us again. We're back. You're wondering what the hell's going on? Pete, tell them.
Bottom right-hand corner, click like or subscribe and turn on notifications if you're in YouTube. If you're not, if you're on your podcast player, please subscribe to our podcast in whatever view you're using.
Whichever audio platform you're using, please can you leave us a rating, 5 stars ideally, and can you leave some comments as well? We want some feedback. Also, interact with us. Leave us a message on Twitter if you're here, and if you've got this, the code word is pancake. And can you also come on LinkedIn and Instagram? Thank you.
Thank you.
I don't really know what the pancake thing is about. I just made it up there.